I'll be talking about drug decriminalization and safe supply, looking at the public health and social justice considerations, or some public health and social justice considerations around that. And in terms of an outline, I will look at some of the primary justifications that are in place or have been in place for the criminalization of drugs, and very briefly review how the war on drugs affects minoritized communities in relationship to these justifications directly. I'll look at some of the available data on models of decriminalization and partial legalization, and also look at a suggested model for partial legalization to address the overdose crisis, and then leave ample time for discussion. And in terms of why I wanted the opportunity to be able to bring this up at a grand rounds, I think, first of all, it's something I've been wanting to take a deeper dive on myself and learn more about. But big picture wise, the illegality of most psychoactive substances is a major determinant, social determinant of health for people who use or have used these substances, and for their and our communities. And so if we're going to really look at improving the health and well-being of our patients, especially in this overdose crisis, it's important to really look at the war on drugs and its harms and benefits, and have an opportunity to talk about them and see what we want to do about that. So starting with premise number one, that drug prohibition protects people from the harms of dangerous and addictive substances. This first premise is kind of understood as being what underlies what we take as a given about most drugs. And if we look at that within the history of drug prohibition in the US, we can't separate it from how drugs have become criminalized, which is primarily through racist stereotypes that were justifications for prohibition along the way. And I've included the main examples here, starting with the anti-opium laws in the 1870s that targeted Chinese immigrants, anti-cannabis laws that targeted Mexican immigrants in the 1920s. Black Americans have been stigmatized in association with drug use in the 1950s with heroin, crack cocaine in the 1970s, the 1990s. And in the 1960s, we know that cannabis was associated with hippies and opposition to the Vietnam War, and heroin with Black Americans, and more recently, fears around methamphetamine use were tied to poor white Americans. So we also have to ask which harms from drug use come from the drugs themselves, or if we can even separate them from the drugs themselves, and then the environment of drug prohibition and its enforcement. And if we look at the enforcement of drug laws, we can see that they continue to this day to be discriminatory. Black and Latinx people account for 40% of the people incarcerated in federal prisons for drug crimes, yet account for just 13 and 18% of the general population. And Black Americans are incarcerated in state prisons across the country at nearly 5 times the rate of whites. And this was an interesting statistic that I discovered while doing this presentation, which is that Wisconsin actually leads the nation in Black imprisonment rates. 1 in every 36 Black Wisconsinites is in prison. And Latinx people are also more likely to be incarcerated than non-Latinx whites over drug offenses. And lastly, it's not just the incarceration, but the low-level drug offenses themselves lead to accumulation of prior convictions, and it has a lifelong effect on people in terms of becoming involved in the criminal legal system. And here we can see some fairly recent data from 2015 census and FBI data. And if we compare the rates of drug use and sale by race to criminal legal measures, it's clear that Black Americans are disproportionately arrested and incarcerated for drug offenses compared to white Americans. And on a state level, Black people are about 6.5 times more likely as whites to be incarcerated for drug-related crimes. Sorry for the cat. Premise number two, that drug criminalization is necessary to protect young people from the harms of drug use. But this graph here is a striking example of historical disparities in the enforcement of drug offenses, and that occurred around the time of Reagan's declaration of the war on drugs in 1982. And as you can see, that the rates of arrest for non-white American youth climbed steeply in this period of time, while they went down for white youth. And if one of the primary justifications for keeping drugs illegal is to protect youth from the harms of drug use, we really have to look squarely at how drug criminalization itself has affected primarily Black youth in our country. And this graph, I actually just discovered it in recent days, which is that in the last year, we've had our first drop in drug and alcohol use in teens in this country since 1975, which is an interesting thing in and of itself, and I'm not sure people really understand exactly why. But the other point of putting this up here is to demonstrate that drug prohibition has not lessened the degree to which young people use drugs and alcohol. And this is a joint statement published by John Hopkins in the Lancet in 2016, and it really summarizes the overall effects of drug prohibition on a public health level, which is also to generate and perpetuate this parallel economy that's run by criminal networks. And as I've stated in the previous slides, it feeds into the excessive use of incarceration as a drug control measure and discriminatory enforcement of drug laws. And we know that there are increased vulnerabilities for women, children, and LGBTQ people as well. There's also contribution to the overdose risk with the unregulated illegal markets, as well as limits on harm reduction. And on another note, that the prohibition itself doesn't create a very promising environment for research, for a research base, as well as how assumptions about drug use play into what are appropriate topics of study. So a third major premise which is without punitive regulation, if we're going to try to justify all these harms, and that's why we're looking at least the models that we have so far regarding criminalization can be helpful. So in 2001, the country of Portugal decriminalized individual drug possession and use, meaning that it was illegal only under administrative law. There was no prison sentence or criminal record attached. With that, there was also a dramatic scaling up of health and social services, and people were voluntarily referred to dissuasion committees where they were assessed for problematic use and offered treatment as well as harm reduction. But it was not a requirement for them to engage in these options. And the effects on health outcomes, including overall drug use, have been positive. Portugal went from having one of the highest rates of problematic drug use in Europe to a rate that's lower than most European states. And they had falling HIV rates, which was a primary driver for them to do this in the first place, from 52% in 2000 to less than 6% in 2015. And there were also falling overdose rates, down from 36.2 per million in 1999 to 5.2 per million in 2015, when the European average was still at 20.3. And again, it has not led to increases in overall drug use, and they've also seen decreased incarceration for drug offenses, down by 40%. Oops, let's get over here again. And in fall of 2020, here in Oregon, their Measure 110 was passed, which similarly removed criminal penalties for the possession of drugs. It's too early for us to have a lot of data on this, but they knew based on prior arrest data that thousands of individuals would avoid lifelong consequences. And it's important to remember that drug arrest does create lifelong perpetuated consequences. And with the $302 million of funding that was made available through this shift in priorities, there has been increased access to treatment and harm reduction and housing support and peer support specialists. And also positively, several other states have launched similar bills or campaigns. And this sort of kind of taking the lead on something that's relatively controversial is commonly a way in which we can manage to have progressive change throughout for policies like this in our country. Which is leads me to talk more about harm reduction overall. And in a way, harm reduction is a form of decriminalization in that each measure that's been taken over the years did require some degree of a legal battle and the work of activists and healthcare advocates to make these public health approaches more available to people, starting with needle exchanges. And still continuing to this day in terms of naloxone prescribing and Good Samaritan laws about actually using naloxone. In various parts of the country, drug testing strips are still considered paraphernalia and are criminalized. And there are also Good Samaritan laws for calling 911 on overdose events. And I know that here in Wisconsin, as well as many other places, they're suboptimal still in terms of protecting people from downstream effects of trying to get help in that situation. And now safe consumption sites, with our first safe consumption site in this country that's been sanctioned in New York City as a, and this does herald, this demonstrates a change in attitude over time and hopefully heralds room for us to add more to the services that we can provide in a harm reduction type of space. So despite expanded treatment, which so much of the funding's been moving towards, and harm reduction efforts, overdose fatalities continue to rise. I'm sure most people here are already aware of the numbers from 2020, where there were over 100,000 overdose deaths. And this is primarily, these increased fatalities are primarily due to illicitly manufactured fentanyl analogs in the adulterated drug supply. And this is demonstrated here in this graph, where you can see the sharp rise of synthetic opioids. We also know that there's been a rise in terms with cocaine and other stimulants. And it's not entirely clear to me, I wasn't quite able to find full information on the degree to which this is related primarily to fentanyl adulterated stimulants, polysubstance use, or the over potential toxic effects of using these stimulants alone. So the question that I think is really important here is, how do we effectively address the overdose crisis without directly intervening upon the toxic drug supply? And this is a question of legalization, where safe supply comes into play. And I think it's even harder to imagine the changes that would need to take place for drugs to become legalized in our country. But partial legalization has a precedent, and it has been shown to have benefit. So I'm going to look into some of the models we've got in place already throughout the world, not here in the US, for partial legalization. And I just, when I think about this, and I think about the difficulties around legalization, at the same time, when there's an average of 273 people who die per day of overdose, it's hard to say that we can even afford to discount this option. So safe supply, and in this discussion, I'll be focusing on regulated alternatives to illicit opioids. This is an interesting viewpoint. It's a bit tricky, but at some level, opioid agonist treatment is a form of safe supply. And it is tricky because there's still a huge amount of misunderstanding, even within medical communities and outside, that methadone and buprenorphine are legitimate treatments for opioid use disorder. But that said, It does function as an alternative to illicit opioids for people who have use disorder. And we know that increases social functioning. They increase social functioning and reduce opioid-related morbidity and mortality. And some of the characteristics that make them acceptable have to do with the long-acting nature of these medications, the measures that are in place to reduce diversion, for better or for worse, and the pharmacokinetics that reduce overall risk, especially with buprenorphine. And we know that these medications provide great benefit to people who are seeking recovery from opioid use disorder or in various stages of that. But there are also the retention rates and the duration of treatment rates are not ideal. And we do know that a lot of people continue to use illicit opioids and other substances while they're on both of these medications. This is demonstrated by the last bullet point on here, where they just looked at the number of patients in a methadone maintenance clinic in Michigan in 2015 to 2016. And even then, 64% were testing positive for fentanyl at least once, and often with metabolites for cocaine and or heroin. So even though it's important to continue increasing access for medications for opioid use disorder, it's not enough to dramatically affect overdose fatalities in the current toxic drug supply. So injectable diacetylmorphine, or injectable pharmaceutical grade heroin, has been looked at in Canada and Switzerland as well. But the first study here is comparing diacetylmorphine to methadone for treatment of people who had what was considered refractory opioid use disorder, where they had at least two previous treatment attempts, including treatment with methadone maintenance in between 2005 and 2008. And they looked at rates of retention and treatment, which were quite good in the diacetylmorphine group as compared to methadone. And they also looked at rates of illicit drug use or other illegal activity, which was also increased, which was actually decreased. I have that flipped. And that there were decreased use of illicit heroin, but no significant change in the use of illicit cocaine, which does tie into, once again, this running theme that we also have to look at the toxic drug supply with stimulants if we're going to try to decrease overdose risk. This other study is a systematic review and meta-analysis looking at comparing randomized trials, comparing diacetylmorphine to to methadone. And overall, they found that there was an increased or equivalent retention rates, decreased illicit heroin use, and higher responder rates overall. And they had various predetermined scales for deciding this, as well as evidence of cost effectiveness. And in Canada, they've also studied using injectable hydromorphone, and then coming from the base of the benefits that they could see from injectable diacetylmorphine, comparing injectable hydromorphone to that, and primarily trying to see if it was non-inferior for treatment of long-term opioid dependence. And in this first study, which randomly assigned 202 patients to either injectable diacetylmorphone versus hydromorphone for 6 months, there was non-inferiority demonstrated for days of street heroin use, at least in the per protocol analysis, not in the intention to treat analysis. And there was non-inferiority for total days of any street opioid use for both analyses. And this second study also compared hydromorphone to diacetylmorphine, but had an open label portion, and where they were basically trying to see if hydromorphone would be found acceptable as an acceptable alternative to diacetylmorphine. And they found similarly high retention rates, even with the people who were in the open label hydromorphone arm of this. And the doses didn't differ significantly between the two, blind versus open label. And so they concluded that hydromorphone can be offered open label to retain patients in treatment. And this is just a summary of these the partial legalization of injectable opioids for opioid use disorder, short acting, and that again the benefits were demonstrated by these studies. The limitations, of course, here in the United States have to do with regulations. Neither of these clearly are approved for use, or there are no opioids that are approved for use outside of methadone and buprenorphine for treatment of opioid use disorder. And they're also not suitable for people who don't inject or who have difficulty keeping engaged in healthcare settings. And they can be difficult to implement overall, but also in rural and remote settings. And then, as expected, some of the common concerns might be the potential for diversion. And this might be something that we'll want to discuss, but I think there's always a risk-benefit line that we walk when we're using opioid agonist treatment in terms of how to identify the risk of the actual risk of diversion with benefit for our individual patients. And then I have this as a full quote because I think it summarizes another key point, which is why we're even looking at this to help with the overdose crisis, or why I think it should be considered. But not all people who use opioids are interested in treatment, and nor is conventional treatment suitable for all people who use opioids. And if we continue to rely only on treatment models amidst evidence that these don't work for everyone, this represents a fundamental failure of our attempt to adequately address the overdose crisis as it is. And this, a lot of the data that I got actually on these available options came from this article by Ivsons et al. And they offer at the end an off-label hydromorphone tablet program, which is much lower barrier and easier to upscale, and has been implemented in at least these two locations in Vancouver. And just to get a sense of what that might look like, both of these are either in or adjacent to an overdose prevention site. And in one, the nurse within the overdose prevention site distributes about 70 milligrams of hydromorphone a day in oral tablets, at least 1 hour apart, up to 5 times a day. And the people attending this OPS can either consume orally, intranasally, or by injection. And for, diversion prevention, the pills are crushed by the nurse, and then oral and intranasal use is witnessed, or injection supplies have to be returned after use. And the second situation has an automated dispensing machine adjacent to an OPS. So, in summary, safe supply is a potentially viable option, but we have to think of it beyond just the terms for treatment alone for opioid use disorder, or treatment towards abstinence and recovery more narrowly, because for it to be effective, it can't just be about the drug itself. It's clearly important that we have to have legal, non-adulterated, and of known quality substances available for this to work. But there has to be allowance for user agency in the consumption practices, and an emphasis on harm reduction rather than abstinence use, which ties in to avoiding punitively impacting treatment based on the participation in the intervention. And that is the end of my presentation, and I'm going to open it up for discussion, as I anticipate there are probably questions and many things that people might want to talk about.
Great, thanks for putting that together, Rebecca. Really appreciated it. Interesting to consider, right? I mean, I think a number of these interventions perhaps should be thought about differently, given points you made around the landscape in terms of the drug supply that we have now and the dangers inherent to it. So, yeah, I think it was really timely to be presenting this and thinking more about it. But yeah, we can open it up if there are any other comments or questions.
This is Elizabeth. Really, really nice job, Rebecca. One of the things that sometimes comes up, and it might be an interesting sort of jump off point for discussion, is just There have been some studies to show increasing use of cannabis in states that have legalized cannabis. And I was just looking, I vaguely remembered I saw a JAMA Psych paper and I found it looking at not only increased rates of use, but increase rates of what do they call it? Like problematic, or no, actually this one was cannabis use disorder after legalization. And I just think as we have these conversations, like that's one of the things that often comes up of like, well, we've tried it and we actually did see increasing use. And so I'm just curious, like if you have immediate thoughts for how you might respond to a question like that, or if in your readings, like, you know, you had different interpretation.
I didn't actually dive into the numbers for that, um, just in terms of time. But as I think about it, um, it is a little bit of a different scenario. I mean, it's definitely a different scenario, right? And I guess I would wonder what the starting off points for use were and what that increase actually was. And and it's it's a different there are almost different just motivations on the level of being able to justify it on a political level for people between cannabis versus considering um, the urgency of overdose from other substances and balancing the harms and risks from that, and also the degree of normalcy. Because I mean, the numbers of people who use cannabis versus some of these other substances are, are significantly different. Is that true, or am I just kind of pulling that out of a, a, a gestalt?
Yeah, I mean, past NSDA data do show that Americans by and large use cannabis at higher rates than they use other like illicit substances. Across probably all. I actually don't know. Alcohol may be the one exception. I'd have to go back and look more closely. But alcohol is not illicit. Yes, I mean, absolutely, there are higher rates of use sort of before legalization. And I think, when we think about quote unquote experiments, they weren't set up as experiments, natural experiments in the United States. I think, alcohol prohibition and then subsequent removal of prohibition and then cannabis are probably the two examples we have to look at. And so I just think it's an important thing to think through. So yeah, at baseline, rates of use are higher for cannabis. But that recognition that we have seen increasing use in states that have legalized when they compare pre-post, and increasing rates of normalization of use among youth, and a perception that it's safer because it's legal, which is probably true, right? There's a little bit more regulation around it if you're getting it from uh, a dispensary. So yes, I think that would just maybe be something as you think about this discussion to think through and
Right.
really comb through the literature.
Yeah, I mean, I think the thing that complicates that discussion even further from a population health perspective is the extent to which possibly, particularly among youth, that cannabis and alcohol at some level could be economically substitutable products, where if marijuana use goes up and alcohol use goes down, odds are that's to the good in terms of public health globally. But that's an empirical question that is probably going to take a while and probably won't be answered because there isn't going to be a randomized design to it.
And I didn't look at this. It might be interesting to look at the rates of cannabis versus other previously illicit drug use in
Right.
Portugal too, for youth, for young people, or any age.
And I think with the I'll be interested to go back into the literature around cannabis too has been evolving so much lately that it's been a little difficult to keep up with. But one paper I also remember seeing that was kind of interesting was that the findings there, because there have been some conflicting findings, was that in states where there was outright legalization, adolescent use on average had remained flat. And in states where there was medical marijuana, it had actually decreased, which to your point, Elizabeth, may be some indication that normalization by way of recreational use sort of may be perceived differently in terms of the perceived risk attributable to using cannabis as opposed to it being medicalized, which was kind of an interesting finding to me.
I will just say I've had the opportunity to visit Portugal and Vancouver, and I saw that vending machine the first week it was open. And I think a lot of this, when we think about, like, a lot of it devils in the details. And I was working in public health when some of the cannabis legalization started, and I think there was a lot of frustration among the prevention community in particular that we weren't really doing a great job of regulating cannabis and using lessons learned from big tobacco and big alcohol. And I think that, interestingly, because we have the experience with cannabis and alcohol, and we know the risks for adolescents in particular, and we know marketing strategies, and we know, like, when you get big money behind these things. And I don't know that, like, for example, decrim or legalization would look like that for all substances, but like that we actually haven't done a great job. And partly that's that, things pass from a legislative standpoint. You don't always get more staff to actually think or have time to think through regulation. But what I would say in particular in Portugal was that, yes, they've saved money. Yes, but they also invested heavily in a ton of social services. Homelessness is rare, and so there are like, healthcare is uh, accessible to everyone. You can go to the equivalent of a recovery home for years. Um, and so I think, it's really important to contextualize some of, like, okay, they did this, these were their outcomes. And it's equally important. And I think when we look at decrim as a whole, it's that same thing. Well, if we're going to save money in criminal legal, like, that has to move to social services. And I think that's been a lot of the discussion in Seattle in particular, of just the need for more social services as we're saving money in the criminal legal space.
Yeah. I see, Joe, you've had your hand up for a little while. Did you have a question?
More a comment. It's like, and it kind of follows with that. Its safe supply is tied in Portugal and in Vancouver is tied to treatment, not just like, oh yeah, you can just get it, as opposed to, legalization of marijuana. Yeah, maybe medical marijuana, there's a little bit more oversight. But when it's just like recreational, and I think exactly right. It's like if it's tied to treatment, then it has had a positive impact in terms of reducing morbidity and mortality.
Yeah,
and
I think
decreasing criminalization.
Yeah, I mean, I think the other important part of that point, by way of expanding social services and rethinking the role of law enforcement and criminal justice in some of these programs, is that we know from surveys that criminal justice-based treatment programs have often led to lower thresholds for arrest for fairly minor charges, where an officer is, in essence, making a clinical decision about a person's treatment need based on a fairly minor drug-related offense, which is partly what has led to some of the congestion with diversion programs as well, which also need to be rethought.
Well, OWIs for alcohol and fatal motor vehicle accidents have not decreased. In fact, states that have legalized marijuana, there's increased OWI fatalities. And usually it's alcohol, but oftentimes it's combined with marijuana. So I think that just making a safe supply for the psychotropic medications that impairs judgment, impairs reflex time, is not the right way to go. I think, and when you talk about, criminal justice systems, and police officers making, an arrest for an OWI, I mean, I think it's, in Wisconsin, it's kind of like, we do we take away driving privileges, and then eventually there's a criminal process involved depending on what the number of OWIs that the person has had. But I think, it's just that just legalization without that kind of tied to treatment and tied to, people that are using illicit is kind of like, I don't think that's the right move to make. I think, and I don't know what's going on in the rest of Europe. I mean, Portugal is kind of, they spend a lot of money on social services, and which has really had a positive impact. And Canada's the same way, at least in Vancouver, what they've done with legalization of heroin, they've been doing that for years, and it's a positive outcome. And using those vending machines, it's not for anyone to kind of just come up and say, oh, I want some hydromorphone.
Right.
No, you have to have, your identity card, and it's dispensed according to what was prescribed for you.
I mean, and this horse is already kind of out of the barn, but I mean, another argument I've heard is, well, if cannabis had been regulated differently in years past, then we wouldn't have the synthetic cannabinoids, which are much more strongly associated with more acute and sometimes catastrophic harms. And similarly, I suppose that question could be asked around heroin. If that was regulated differently, would we be having the struggles that we're having currently with fentanyl and analogs in the supply? More of a thought question again, not one that I think we can answer with certainty.
Great talk, Rebecca.
Thanks.
Yeah, thanks a lot for putting that together. Really appreciate it. That's great.